so you heard Dr. Griffith and Dr. Behar presentation, and they presented very clear evidence of how important and really relevant for optimization of classification, prognostication, and therapy are molecular testing. I don't want to be the devil's advocate, but I will just change gear and see what we have in reality. So these are my disclosures. Okay, this is the first question. What is your opinion? What do you think, which do you think is the percentage of MDS patients worldwide who undergo NGS analysis? 50%, less than 50, 80, more than 80%. Okay, I think you have quite clear ideas, but I want you to discuss how these things can be, defined. Okay, so we just saw it. I will be very short in this, but we saw that the 2022 WHO classification beyond cytogenetics require at least SF3B1 and TP53 biallelic and monoallelic determination. So we need to have this to classify MDS, so to perform a good diagnosis. And the same is true for ICC, again, SF3B1 and TP53, this time MDS AML together, but it doesn't really change what we have to do to optimize our diagnosis. And not only that, but we heard that co-mutation of SF3B1 may indeed impact profoundly on outcome, and here also on the classification. So you see, we really have to engage ourselves in a profound molecular testing to reach the level that we have been indicated with. So when we talk about integrated diagnostics, we always indicate NGS after cytogenetic, and together with flow cytometry, we will have to discuss these in the future as well for MRD, but NGS, it's a very important part of our diagnostic procedures. And we heard, I don't want to repeat myself, on how important it is to stratify prognostically patients thanks to these molecular variable that upgrade and only very rarely downgrade patient in terms of prognosis and outcome. So it is complex. There are more than 30 variables that have to be evaluated in IPSS-AM. And beyond, once again, besides cytogenetics, we have a series of mutations. Some of them are not usually included in the more, let's say, more common panel of genes. So we should take this also into account. And although rare, they have to be evaluated, beside what we already discussed about the multi-hit definition of TP53. And on top of that, you see here another group of 15 genes that has to be evaluated. So this is a panel of genes that is quite different in some features from what I have seen around and what is available in several laboratories. But I would like to add something we didn't touch upon today, which is the germline predisposition. To evaluate germline predisposition in patients, we should indeed perform molecular analysis only with NGS, or even considering WES as a sort of approach. This has been a subject of discussion, and we will have to face this. Is age the only threshold that we should consider to evaluate germline predisposition? The clinical manifestation for WHO 2022, it's a scalable model. We will have more mutation to evaluate. And the same sort of approach is true for ICC 2022. So we do have these as well to take into account. Now, these are few data I want to very quickly show you. These are around 500 patients in my center, we evaluated DDX41 that was present in nearly 7% of patients with a median age of 69, and CSF3R present in less than 2%, 1.33, 70 years of age. So actually, these patients are not frequent, but they are there, and their outcome can be different. So we should evaluate them as well, considering only age of diagnosis, for instance. And we did it for 31 consecutive patients, so a small group with the diagnosis of MDS performed at age less than 60. And as you may see, our patients were presenting a germline variant in a very high proportion of cases, 54%, and a high confidence germline variant was present in 12 or 17 patients. So this is a real problem we have to face and to consider before starting therapy for a patient. So there are open issues. We heard the evidence, we discussed them. I think we are all convinced that this is the way to go. Will future therapies be based on individual molecular signature? Maybe, yes, this is the way to go to obtain better results. But are we allowed to rethink the study design and clinical endpoints based on the new classifications and prognostic score? We had some failures in several phase 3 studies for MDS. Maybe redesigning them, taking into consideration molecular pattern more than in the past, would be a winning strategy. And one question we all have is the future approval of new agents. Will the future approval of drugs by health agency will be based on IPSS-M as it was on IPSS and more recently will be for IPSS-R? So I took the liberty to ask to a group of colleagues and friends, and I pestered them with my request, what were the situation in the different countries. So these are all personal communications. They can be not extremely precise, but they give you the picture of how we stand in 2022, at the end of 2022. First of all, we have to distinguish in academic and community practice. So as you see in the US, 90% of patients who are seen in academic center do get NGS, but probably less than 50% do get the same assessment, molecular assessment in community. Canada is a very complex situation. 80% of patients in clinical trial in academic center do get NGS, whereas in the community, it's difficult, and I will come back to these in the following slides. Australia has, it's a huge country, very few inhabitants, and the legislation and regulation for reimbursement are very difficult and complex. So less than 50% of patients in academic center who will get NGS. Who are they? The reimbursement is only for patients who are eligible for hematopoietic stem cell transplant. And it's probably a very sporadic NGS assessment for patients in outpatient clinics because it's not reimbursed. Europe. In Europe, as you know, we have a national health system that is reimbursing, but as you see in Germany, both putting together academic and community evaluation because of the centralization of the test is 75%. In France, I got the data only for the academic center, 80%, not well known for the smaller center and community. In Italy, we have almost 90% for academic and patient undergoing a clinical trial, 47%, this is a real number, for the patients in smaller center and community. Spain, 90% of the patients who are in academic center, and very sporadic in community. So this is why you have these differences. So in the US, the NGS is fully reimbursed by major insurance only for patients who have a certain diagnosis of MDS and not for pancytopenic patients or the one you have doubts about. and generally is for less than 50 genes. Canada, as I mentioned, and I thank Rina Buchstein for enlightening me about this, there are deep regional differences. So some regions do not reimburse at all, and the patient has to pay for it. And it's more than 850 Canadian dollars. Australia, as I mentioned, very complex, reimbursed exclusively for inpatient eligible for stem cell transplant. Outpatient must pay, and again, the price is in between 600 and 800 Australian dollars. Brazil, not at all reimbursed, patient pay for it, and this is only, of course, mainly for patients who are in private clinics and patients who are enrolled in clinical studies. Europe, as I mentioned to you, is fully reimbursed, apart from Spain, is not reimbursed, but the 90% I showed you is because the MDS Spanish group has generated a program, an umbrella program, to support all the cost for all possible MDS cases. So you see very heterogeneous situation. Of course, I do not have the data of many other countries, and I will be happy to complete this survey with you. The most complete data have been given to me by our colleagues by the Latin America MDS group. Why I point it out? Because in Latin America, there are more than 600 million of inhabitants, 25 countries, very different system and health system. So you see, these are the centers and nations who responded to the survey that was led by Carolina Belli. And you see, these are the questions, and the availability of NGS in Latin America increased from 16% in 2019 to more than 40% in 2021. The perception then of the physician is quite heterogeneous. In 2021, at least 24% of centers could perform the NGS evaluation in more than 75% of patients. But when you ask to physicians, you see these are the different nations, and when you ask how many patients can you fully evaluate with NGS, you see that the responses are quite heterogeneous. So not all the patients can be studied, and in some nations you do not have at all the availability, as you see here. Mexico has the highest availability of NGS, and you go down with a very deep heterogeneity in the different nations. And some Latin American countries cannot really have easy access to NGS. And these are data that were given to me by Sofia Grille, who presented it. And we go back to the essentials. So the availability of TP53 mutational status determination, again, you see is not evenly distributed, and not all the nations and countries can provide it for their patients. So this is something that we should really take into consideration and be aware of. And how can we, as MDS Foundation and community of hematologists, can we increase the awareness of the relevance of the molecular characterization for our patients? The Ministry of Health of different countries should be really sensitized by real-world validation. What I showed you is just a partial vision of what is happening. So we need molecular characterization. We need to lower the price, of course, of this test, because we need to have IPSS prognostication, but also the ability to classify our patients in the best way. And as we always mention, we have to give equitable access to diagnosis, prognosis, and provide the best available treatment. So what about the approval of drug I mentioned before? If the health agency will approve drug on a test that is not available worldwide, or there are countries who do not have it, well, that will be quite difficult to manage. So this diagnostic testing should be much more available. So are we possibly, and I don't know whether this is something we should do at all, can we give a threshold for a minimal acceptable molecular diagnostic? Are we possibly identifying patients in which molecular analysis by NGS is really absolutely mandatory? I would say all of them, but can we subselect some? Or can we just indicate patients who need only TP53 and SF3B1? And can we sort of put on a side some patients who are only receiving supportive care? Is it this ethical? Old age per se cannot be a discriminant. Some countries do select patients on the base of age, and patients above 80 are not tested for molecular somatic mutation or molecular alternation. And can, as I mentioned before, young age, on the contrary, be indicative of the need of germline predisposition evaluation? Now, I wanted to show you here a picture of a super young 80-year-old patient and the one that is sitting in a retirement home, but I don't need to do so. We all need, our patients are very different, even with the same age. So I'm very much grateful to all my friends who helped me at the very last moment. A lot of, I'm really happy to show you the name of the colleagues in Latin America. They're working very hard to raise the bar and to really give the optimal treatment for MDS patients, and all the others. I hope I did not forget anyone, but I'm ready to work with them on this subject again. So again, this is my post question. So what is the percentage of MDS patients worldwide who undergo NGS analysis? Yes. I think this is, unfortunately, the right answer to my question. So I really wish to thank you for your attention.